Besides lungs, patients may also have extra pulmonary involvement, which may affect their survival or lifestyle of living. So basically, this disease is the limitation of the airway flow. The primary problem is the limitation of the airway flow. When you treat these patients, the limitation is not fully reversible. Unlike asthma is reversible, but COPD is not reversible. It is progressive. So that's the limitation. So that's why we try to talk to these patients. The only thing that can affect the progression of the disease is their lifestyle. If the patient is a smoker, they need to stop smoking. If they work in an environment where they come into contact with pollution, chemicals, they also need to avoid that environment. So smoking cessation is one of the components in terms of managing COPD. So when we say COPD, basically there are two disease components that make COPD. There are two disease components that make up COPD. Chronic bronchitis and emphysema. Chronic bronchitis and emphysema. So when you say COPD, you're looking for both chronic bronchitis and emphysema. Now the bronchitis basically is going to involve the bronchioles. You may find that the patient may be, one of the symptoms patient may have is coughing, sputum production, and that's because the bronchioles become inflamed, and because they're inflamed, they tend to be narrow, and patients tend to trap mucus within that bronchioles. So that limits airflow in terms of the air exchange. Whereas when you have emphysema involved, emphysema usually is going to be at the terminal bronchus, basically the alveoli. The alveoli will be disrupted and they become large. Because they become large, they tend to trap air. So that's why you may also see some of these patients have barrel chest, because they have a lot of expanded air volume in the lungs. The alveoli will lose the elastic record. The alveoli will lose the elastic record. So that happens at the terminus of the bronchus. That's where the air exchange takes place. So emphysema basically involves the alveoli, damage to the alveoli, whereas the bronchitis involves the bronchioles. They have inflammation and accumulation of mucus. Okay, so in terms of chemical features, if we want to differentiate asthma from COPD, usually the most common cause, about 90% of COPD will be a result of smoking. So smoking is usually present in COPD. So smoking, or they can be exposed to dust, or they can be exposed to chemicals. So smoking is by far the most common cause. The age of onset, usually after 40 years for COPD, but asthma can develop young age. Now, if the patients develop COPD before they get to 40 years old, then we need to check antitrypsin deficiency. Antitrypsin deficiency, which basically affects the alveoli. If we develop COPD before the age of 40, then we need to check for antitrypsin deficiency. So another thing you find in this patient, they have a chronic cough. Breathlessness is persistent in COPD. Now, if we look at the cells, eosinophils, it tells you for COPD, it is absent. That's true. However, if this patient has an exacerbation where they have bronchial involvement, chronic bronchitis, and you plan to use inhaled corticosteroids. You plan to use inhaled corticosteroids. The presence of neutrophil will tell you whether the patient will respond or not. Even though it stays absent, in chronic bronchitis, when you have exacerbation, you have increase in neutrophils. So we'll talk about that. So that's an exception here. In terms of using inhaled corticosteroids, you check the neutrophils. Usually if it's 300 or more, that will indicate that the patient is going to respond to the inhaled corticosteroids. Okay. Now, chest X-ray does not help in making a diagnosis of COPD. Chest X-ray does not help, but it can help to rule out or rule in other conditions. Other conditions that can also cause shortness of breath, like pneumonia, CHF, pleural effusion, or pneumothorax. Chest X-ray can help with that, but chest X-ray will not help with the diagnosis of COPD. In terms of physical exam, the findings, this patient will have prolonged expiratory effort. Now, when they exhale, it takes longer. It takes longer. I just talked about the alveoli losing elastic recoil. So it takes longer for them to exhale. So you may find this patient using what is called accessory muscles to try to exhale. They may also purse their lips as a compensation. And you may also hear them grunting. Now, some patients can compensate by changing their posture. Some may lean. Some may sit in a tripod position. These are some mechanisms they use to adapt. And on physical exam, this patient will have barrel chest because of the accumulation of air in the lung. They have barrel chest. So they are barrel chest. So these are some position I just started. This will be the tripod position, and this will be forward-leaning position. This is an adaptation to try to exchange air. So in terms of diagnosis, remember, chest X-ray does not help in the diagnosis, but the chest X-ray will help to rule out other conditions or rule in other conditions. So the diagnosis basically will involve the presence of chronic cough, chronic sputum production, and shortness of breath. So you have these three. Then you need to find out if the patient has a history of smoking, the patient has a history of occupational dust, or they've been exposed to chemicals where they work. So all this will help you to make a preliminary diagnosis of COPD. All this will help you to make a preliminary diagnosis of COPD. For you to confirm it, then we need to do spirometry. So when the patient has all this, you give a preliminary diagnosis. So some physician may start treating the patient until they get the result of spirometry. But spirometry is what's going to confirm whether this patient has COPD or not. Okay. So the pulmonary function test helps with disease diagnosis, specifically with spirometry. And it will also determine the the disease severity in terms of airflow limitation. How severe is the disease? The severity, yes.
The previous slide. Is that something that the patient will tell you that they're experiencing in order for the chronic sputum production?
Yeah, they will tell you this. This is what is actually going to bring them in.
Okay.
Then during the history, you want to find out this.
Okay. So this is something they'll tell you that they're experiencing. Okay.
Okay. Chronic cough, sputum production, dyspnea, especially dyspnea, that's what's going to bring them in. Then during the history, you're going to find out about this.
Okay.
Or you said that the patient with the alpha antitrypsin deficiency, that one you said is only for anyone that's younger than 40. So if they're older than 40, we still have to give them that test.
You don't need it because we expect to see it after that age. So if you see it before they get to that age, then you need to check for antitrypsin deficiency.
So after 40, we don't have to ask and get them to screen for that.
No. After 40, the reason after 40 is because of the effect of smoking. It takes time for you to see the effect of smoking on the lung. But if you develop it early, then you also need to rule out after one antitrypsin deficiency. So with the pulmonary function test, will help you with disease diagnosis, and it also determines the airflow limitation in terms of severity. And in terms of severity, we have 4 stages based on the GOLD guidelines. We have the mild, moderate, severe, and very severe. So we use the spirometry to also determine that. So spirometry, basically, we're looking at the first expiratory volume in 1 second, FEV1, and we also look at the forced vital capacity. So basically the patient will take a deep breath, and the technician will tell them to exhale forcefully. Exhale forcefully. During that forceful exhalation, within the first second, that's where you're going to capture the FEV1. Within the first second, that's when you capture the FEV1. And at the end of the expiration, that's when you get the FVC. So you're gonna take a ratio of it. You're gonna divide the FEV1 by the FVC. You're gonna take a ratio of that. Divide the FEV1 by the FVC. If it's less than 70%, that tells you they have restrictive airway limitation. So that's what you use to make a diagnosis. For every patient who has COPD, the ratio should be less than 70%. For every patient. But it doesn't tell you, that ratio doesn't tell you the severity. It just tells you they have airflow limitation. So we use, again, spirometry to make a diagnosis, to confirm the diagnosis, and to grade the disease. We use it to grade the disease. Okay, right here at the bottom, FEV1 divided by FVC, the ratio should be less than 70%. Okay, so this is what the patient goes through in terms of the spirometry. Clamp the nose and take in air as much as you can, and they forcefully exhale into this equipment here. And during this exhalation, the amount that is exhaled within the first second will be the FEV1. And at the end of the exercise, it will be FVC. So in terms of grading severity, now remember, the ratio will tell you they have COPD. The ratio of FEV1 divided by FVC will tell you, if it's less than 70, will tell you they have COPD. but it does not tell you the severity. To determine the severity, which will be mild, moderate, severe, very severe, we only look at the FEV1. We only look at the FEV1. So you use the FEV1 to determine the severity. You use the FEV1 divided by FVC to make a diagnosis. Is that clear?
Mm-hmm.
Okay. So, for mild, it will be 80 or more. Moderate is 50 to 79. Severe is 30 to 49. And anything less than 30 will be very severe COPD. So, this combined assessment is also very important in terms of managing the patient. To the left here, we have the spirometry that we have to confirm with the FEV1 divided by FVC is less than 70%, so we know the patient has COPD. Then this tells you the severity. Then to the right, we have this A, B, C, D boxes. So basically, what we have here will be the history of exacerbation and the symptoms. What we have here will be the history of exacerbation and the symptoms. So this is very important in terms of how you treat the patient. Very important in terms of how you treat the patient. So the patient is going to fit into either A, B, C, or D. So the treatment will be different depending on where the patient is placed. So let's look at these 4 boxes here. So if we look at the vertical line here, to the left of the vertical line, which boxes do we have?
A and C.
A and C. So to the right, we have B and D. So if you look at the bottom here, we have the MMRC and the CAT. These are some questionnaires the patient will fill in terms of their symptoms. Here in the United States, the CAT is not commonly used. The MMRC is British, but there's also some clinicians use it, but the COPD assessment test is not commonly used. So basically, if the CAT is less than 10, that means the patient has less symptoms. If it's 10 or more, that means they have more symptoms. So, if we look at A and C indicates that the patient has less symptoms because the CAT is less than 10. And if we look at B and D, the patient has more symptoms because the CAT is 10 or more. So that's very important. Now, if we look at the horizontal line, so we have C and D above, A and B below. That will indicate a history of exacerbation. That will indicate a history of exacerbation. So, if we look at A and B, it tells you they have no exacerbation, or they just have one exacerbation in a 12-month period. They either have no exacerbation, or they have one exacerbation in a 12-month period. So that means the risk of exacerbation is low. The risk of exacerbation is low. Now, if we cross that line, we'll go to C and D. The patient has to have one or more exacerbation in a 12-month period. Now, right here we said if the patient has 0 or 1 exacerbation, that's a low risk. However, if this 1 exacerbation leads to hospitalization, then it becomes high risk.
You'd be about to say.
Okay. So, if you look at the data here, it says 0 or 1 exacerbation is considered low risk.
What if you need to hospital?
However, if that 1 exacerbation results in hospitalization, it becomes high risk.
Okay.
And that's in COPD.
So if the patient has one exacerbation but they're not hospitalized, it's low risk.
Yeah.
If they have 1 exacerbation and they become hospitalized, it becomes high risk. So typically, greater than 1 exacerbation will be high risk. Greater than one exacerbation will be high risk. So, if a patient has CAT of 12, if a patient has CAT of 12, where are you going to place it?
B. B.
Yeah, so it can be B or D.
Oh, yeah, B or D, yeah.
B or D.
We have to
I
know
haven't told you about
we need to
exacerbation.
know the exacerbation,
I
yeah.
haven't told you about exacerbation. So it can be B or D
Okay.
because it's more than 10.
Mm-hmm.
So it's going to be here. Okay, so that leads me to the next slide. So the question is, they both have the same FEV1. The CAT is the same. However, patient 2 has 3 exacerbations within the first year, whereas patient 1 has none. So which box are you going to put patient 3 versus patient 1, patient 2 versus patient 1?
D.
Patient 2 is going to be,
And D. And D.
what about patient 1?
That's gonna be in B. That's gonna be in B.
It's going to be B.
B, yeah.
C has to be less than 10.
Mm-hmm. A and C, less than 10. Exacerbation, low high.
C has to be less than 10. A and C has to be less than 10. But this patient has 18.
So
So the patient has to be either B or D. So where you place them depends on the exacerbation. Okay. Yes.
Patient 1 is B.
Okay, make sure you remember this when you're going to see it in your exam.
one of our classmates wants to know if we're gonna have a chart.
Of the exacerbations.
Okay.
More than one.
Dr. Abobo, are
Yes.
you going to be providing us with a chart or no?
What chart?
ABCD chart.
You better memorize.
Because it's more like, I feel like this is more like into a diagnostic, which is what physicians
It's
do.
easy. It's just ABC.
If you are a pharmacist,
So it just goes into.
you just need
And
to
then
know
exacerbation.
physical assessment. Just like the physician, you're not doing the physical assessment, but you should know how to interpret the physical assessment.
This chart, if it's above the chart, it's gonna be.
As a pharmacist, for you to design pharmacotherapy, you need to know where to place the patient. Okay. Okay, answer your question, I don't give you track. I just told you need to remember it. A, B, C, D, you need to remember it. CAT less than 10, more than 10, you need to know it. Okay, so pharmacotherapeutic management, basically we want to reduce the symptoms. Like I said, there is no cure for this disease. All we try to do manage your symptoms. And if you stop smoking, that's the only thing that can actually reduce progression of the disease. We also want to improve their exercise tolerance and improve their health status. by improving health, exercise tolerance, that will also improve their activity of daily living. Now, when the patient has COPD, we have to make sure they have all their vaccinations. So the choices, based on CDC, the choices will include the flu vaccine. And the flu vaccine actually will reduce serious illness, reduce the risk of death, ischemic heart disease, and also reduces the total number of exacerbations. So they need to have their shots. In addition to the flu, we also need to make sure they have their pneumococcal vaccine. Again, depending on the patient's age, depending on the comorbidity, we're looking at the PCV20, and PCV15. So all these are choices you need to consider when the patient shows up. Flu vaccine, do they get PCV20 or PCV15? And they also need to consider TDAP. So all these are the options for the patient with COPD. All these are the options. Okay. Now, when we're managing the COPD, we also need to manage the comorbidities the patient may have. Because these comorbidities may also affect their survival. So we also need to monitor the comorbidities. Not only are we treating the COPD, we're also managing the comorbidities. And the mainstay of management will be a bronchodilator. Bronchodilator is the mainstay of management. They do increase FEV and improve the spirometric variables. Again, these agents, the toxicity may be dose dependent. Now, short-acting bronchodilators are not usually recommended for daily routine use. They're not recommended. Doesn't mean they don't use them, but they're not recommended. The short-acting basically is supposed to be rescue medications that can be used as needed. The short-acting bronchodilators, not the long-acting, the short-acting bronchodilators are the rescue medications. So every patient who has COPD must have standby short-acting agent as a rescue medication. So beta-2 agonists, the short-acting, usually they last anywhere from 4 to 6 hours, compared to 12 hours or more with long-acting beta agonists. And patients can actually be on a long-term long-acting beta agonist, and they become symptomatic. They can also take the short-acting. So the long-acting does not preclude the use of the short-acting. That's why they have the short-acting standby. Also, in terms of the beta-2 agonists, you need to make sure you remember salmeterol and formoterol usually are dosed twice daily. So if these medications are part of inhaled corticosteroid combination, once you see formoterol, salmeterol, you know it has to be twice a day. On the other hand, if you see decaterol, olodaterol, and vilanterol as a combination, you know inhalation has to be once a day. for this, the caterol, and the vilanterol are usually dosed once daily. So whenever you see this in combination with inhaled corticosteroid, I can tell you whether it's dosed once daily or twice daily. Okay. So in the caterol, lateral, and vilanterol are once daily formulations. And of course, in terms of adverse effect, even though this patient inhaled them, you still have some systemic absorption. It's minimal, but you still have some systemic absorption. It's supposed to act locally in the lungs, so you still have some systemic absorption, such that patients can develop resting sinus tachycardia. You can develop resting sinus tachycardia. The patient can also, this medication can also precipitate cardiac arrhythmia in patients. It can precipitate cardiac arrhythmia. Also, if you guys remember from your renal lecture, we talked about managing hyperkalemia. You remember what we talked about managing hyperkalemia in renal? Okay, so one of the things we mentioned in renal is even albuterol to manage hyperkalemia. Because albuterol, beta agonists can drive potassium into the cell. So that's why if you give these patients beta agonists, they can develop hypokalemia. They can develop hypokalemia. So this is why I'm relating back to the renal lecture. Okay. So in terms of the muscarinic antagonists, the standard short-acting will be pratropium, and the standard long-acting will be tiotropium. So we still have epidenium, lycopyrenium, or pyrrolate as long-acting. We also have mepridinium as long-acting. And the long-acting muscarinic antagonists cannot be used as rescue agents. So if you need a rescue agent, you want muscarinic antagonist, you need to use the pratropium. Some clinicians prefer to use a muscarinic antagonist compared to beta-2 agonists because they tend to be longer acting than the beta-2 agonists. Again, even though this medication is supposed to be inhaled and work locally in the lungs, you still have some absorption such that patients can have urinary symptoms. So you need to be careful with patients who have BPH. They also can cause dry mouth. Hypertrophy can cause a bitter metallic taste. And it can also cause some tachycardia. Anticholinergics can also cause some tachycardia. Regarding methylxanthines, theophylline is the standard. You may also see aminophylline. But theophylline is usually an add-on medication when the patient gets to that D block. Again, with theophylline, it has a lot of drug-drug interactions. Smoke can also affect the pharmacokinetics of theophylline. Theophylline also has a narrow therapeutic range. it does have some benefit, but not that great. It does have some benefit, but not that great. So if we're thinking about adding theophylline, we need to know it has narrow therapeutic blood level. It can also cause a lot of drug-drug interaction. If the patient is smoking, that's going to affect the pharmacokinetics of the theophylline. Now, bronchodilators in stable COPD. Again, like I mentioned previously, whenever a patient has COPD, the mainstay will be bronchodilator. You can give it to prevent symptoms or treat acute symptoms. So if a patient has acute symptoms, which type of bronchodilator do you give them? Short acting. Okay. So we're looking at ipratropium or albuterol. We also have some albuterol derivatives that are available. Also, you're going to see a combination of short acting and beta protagonist and the short acting muscarinic antagonist. You're going to get a combination of that. The combination is superior to either drug alone. The combination is SEBA and the FEMA superior to either drug alone. The same thing with the LAVA and LAMA. The combination of the long-acting are also superior to either one alone. Now with oral glucocorticoids, you tend to see oral glucocorticoids in patients who have exacerbation for short-term use. The oral glucocorticoids are not recommended for long-term use because of the systemic adverse events. They don't seem to have a long-term benefit when you use it chronically, and it has a lot of metabolic adverse effect profile. Yes.
Also, I'm sorry, go back to regarding to the inhalers. If they're on the long acting, should we also add a short acting to it or no? Or we don't have to?
If they have increased symptoms, yeah, then you can use the short acting.
On top of the both long acting.
Like I said previously, every patient with COPD must have the short acting because the rescue medication, they must have it available.
Thank you, sir.
Okay, inhaled corticosteroids are very useful in terms of mortality and the long-term decline. And basically, like I said, none of this medication will modify the progression of the disease, but it will help with the symptoms. Now, this is what I mentioned earlier on regarding eosinophils that is absent in COPD, but it will predict who's going to respond when you give it to a patient to inhale corticosteroid. So like I said previously, the neutrophil, the eosinophil threshold is greater than 300. That will predict response. Sometimes you may see a range between 100 and 300. Now, yes, the inhaled corticosteroids are very effective, but also it can also cause oral candidiasis, and another big risk is pneumonia. It can also cause pneumonia. So make sure you remember that. Inhaled corticosteroids can cause pneumonia. PDE4 inhibitors, roflumilast, is also an agent that you can see patients use either the C or the D stage. Now, the PDE4 roflumilast is not a bronchodilator. It is not a bronchodilator. It's an anti-inflammatory agent. Roflumilast is not a bronchodilator. It's an anti-inflammatory agent. Okay. And for a patient to be placed on roflumilast, they also have to have presence of chronic bronchitis. They have to have presence of chronic bronchitis. Remember I talked previously inflamed bronchioles. So you have to have chronic bronchitis for you to add roflumilast. You also want to avoid this medication in patients' risk of depression. It can cause weight loss, diarrhea, reduced appetite. Can also cause some sleep disturbance. Again, this is usually added to patients when they get to stage 3 or stage when they are placed in C or D block. But again, it is not a bronchodilator, it's an anti-inflammatory agent. You may also see patients getting antibiotics. Now, when patients have acute exacerbation, usually it may be due to continuous smoking. Commonly, it may be also due to an infection, viral infection or bacterial infection. So usually the bacterial infection we associate with COPD will include the same organisms that will cause community-acquired pneumonia. The same organisms that will cause community-acquired pneumonia, those are the same organisms you see COPD exacerbation. It is due to bacterial cause. So it may include strep pneumonia, H2, Maracella catarrhalis, and Enterobacter. So these are some of the agents. Strep pneumonia, H2, Maracella catarrhalis. These are common agents you see in community-acquired pneumonia. So when a patient comes in with COPD exacerbation, and they have an infection, even before you determine infection, the patient will be placed on macrolide, like azithromycin, until they determine the cause of the infection. Now, usually when we add an agent like azithromycin, erythromycin, they can also cause increased QT interval, so that's a disadvantage. But again, these are some of the organisms that you can find if the patient has bacterial cause of acute exacerbation. Patients may also be placed on mucoregulators. Most commonly, in this patient getting acetylcysteine. Remember I talked about bronchioles being clogged up with mucus. So you can get this to break up the mucus so that it can expectorate. So you may see patient getting mucolytics, most commonly acetylcysteine. The other thing about the mucus is that if it's not cleared, it creates an environment for organisms to grow. It also creates an environment for the organisms to grow. One other thing you may see in COPD is statins. Now, statins are not indicated for COPD. indicated for a comorbid condition the patient may have. They're not indicated in COPD, but for a comorbid condition that the patient may have. So, as we said previously, in terms of management, so the patient is going to be A, B, C, or D. So that's going to determine how the patient is treated. So when the patient starts initially, they're going to be in the A block. They're going to be in the A block. So this is when they have less symptoms and they have least risk of exacerbation, less symptoms and less risk of exacerbation. So this patient can be on PRN, short-acting agent. This patient can be on PRN short-acting agent. So, but however, when the symptoms start getting more frequent, but it's still less than that term for CAD, you can place them on long-acting agent. You can place them on long-acting agent. Now, when you have more symptoms, 10 or more, when you have more symptoms, 10 or more, then those patients definitely need a longer acting agent. So that's when you get to B. You need a longer acting agent. That's when you get to B. So you can start with a LABA or LAMA. Now remember, when you start on LABA or LAMA, they still have available a PRN need for short-acting agents. So depending on the symptom, how the symptom is controlled, the patient may actually eventually need a combination of LABA and LAMA. And when you get to C, when you have risk of exacerbation, you can actually start what they get in here. And this is where you eventually going to introduce inhaled corticosteroid. When you get to C, that's where you're going to initiate inhaled corticosteroid. And we talked about the eosinophil count in terms of response. Now, if this patient is still symptomatic and they have several exacerbations per year, then we can place them on the D block. So these are all the options. These are all the options. And this is also where you want to, the patient may also be placed on roflumilast. The patient may also be on the theophylline. So basically, depending on the patient's risk of exacerbation, the patient's symptoms, the patient will be placed in either A, B, C, or D, and that will determine how the patient is managed. So typically, the patient just presents for the first time, they're going to start from A, and they're going to progress. They're going to progress based on the symptoms and the risk of exacerbation. Issues related to inhaled delivery. In a hospital setting, usually the therapist will help the patient in terms of inhalation techniques to make sure they have the properly inhalation technique. If they lack proper adequate coordination, they may use, what device do you give them?
Can you repeat the question?
Nebulizer?
what device can you help them to use? For example, they're using a meter dose inhaler.
A spacer?
A spacer. A spacer. If you don't have good coordination, then you need a spacer. Okay. Okay, so these are some of the examples of inhaled medications. Make sure you know the brand names. We talked about albuterol, ipratropium being combined. A brand name will be Convivent. If the patient is getting a nebulizer, you may also see this branded as Duonen. If the patient is getting a nebulizer, you may also see this branded as Duonen. D-O-N-E-D. Again, these are the long-acting bronchodilators in terms of the beta-2 agonists. Again, formoterol, salmeterol, formoterol will be dosed twice daily. And decaterol, lateral will be daily dosing. The anti-muscarinic agent usually the long-acting are usually given once daily. Again, these are examples of inhaled corticosteroids. We talked about, for example, Breo, because it has Lantorol, it should be once daily. Seneca, because it has Meterol, that will be twice daily. Same thing with Salmeterol, it should be dosed twice daily. Now, this is the basis for the use of triple agent. An example would be Trilogy. You see that on TV every day. This is the basis for triple therapy. So in this case, we have inhaled corticosteroid plus LAMA plus LABA once daily versus inhaled corticosteroid plus LABA. Now, if you're going to add inhaled corticosteroid, it has to be to LABA, not LAMA. You need to add inhaled corticosteroid, it has to be plus LABA, not LAMA. Okay. So we'll also have LABA-LAMA combination. If we see the outcome in terms of exacerbation, this is the triple therapy. Over a year's time, you see they have less severe exacerbation compared to the dual therapy. Now, if we look at the risk of pneumonia, the triple therapy versus ICS LABA, the difference is not statistically significant, but both of them are statistically significant compared to LABA-LAMA. So whenever you have inhaled corticosteroid, the risk of pneumonia increases. So that's what this is telling you. And this is telling you here that the triple therapy is superior to dual therapy. So basically, in Trilogy, you have fluticasone, imeclidinium, and bilanterol. Again, because of the presence of bilanterol, it's going to be dosed once daily. Okay, this is just, again, emphasizing the short-acting versus long-acting beta-2 agonist. And this will be anti-muscarinic agent. The short-acting standard will be the ipratropium. And these are the long-acting agents. Okay. Now, make sure you know the brand names. Make sure you know the brand name. Make sure you know the brand name. So if the patient has flare-up or exacerbation, it can be mild, it can be moderate, or it can be severe. Usually if it's mild, the patient can just take what? Short acting. So they can still be at home, take short acting. They don't have to present to an institution. But once they get moderate to severe, they need help. That's when they seek care. So usually they're going to take a short acting agent when it's mild. When it's moderate to severe, in addition to the bronchodilators, the patient may get antibiotics. So in terms of a flare-up exacerbation, most commonly you have an infection. It can be viral infection, bacterial infection. And we talked about bacterial infection. It can be the same organism that causes commonly acquired pneumonia, strep, pneumonia, H. flu, Roxella catarrhalis. However, these are some other triggers that can cause exacerbation. Very hot weather, very cold weather, a very humid condition that can trigger exacerbation in some patients. Pollution, household cleaning material, and also patient can have allergy to dogs, animal or pets. So all these are triggers. That can cause a flare-up. So make sure you know that. So acute exacerbation, we just talked about it, so you're going to give a short-acting agent. Now, if you're going to look at a single agent, usually arbitral is probably the drug of choice. So the patient can be nebulized or they can use the MDI. You don't want to give this medication parenterally because of the risk of arrhythmia or MI. You don't want to give arbitral parenterally because of the risk of arrhythmia or cardiac ischemia. So preferably would be via nebulizer and MDI. The same thing with ipratropium. You want to give it either nebulizer or MDI. In addition, the patient will get glucocorticoid, usually IV, prednisolone or its equivalent. Patient can also get prednisone for short course, about 5 days. Now, the glucocorticoid is added because of the inflammation associated with exacerbation, because of the inflammation. It has no effect on the bronchodilation, it's just because of the inflammation. Ipratropium and the arbitral cause some dilation. Again, Besides, long-term use of oral glucocorticoid is not recommended. If the patient needs to get glucocorticoid, it has to be inhaled glucocorticoid. Again, inhaled corticosteroids have risk of pneumonia,